Today's topic is about the dental caries. If you see the definition of the dental caries is an infectious microbial disease characterized by the localized dissolution of demineralized inorganic and the destruction of the organic substance of the tooth. This is one of the earliest definition which you are reading from ages. But according to the recent concepts of the Caries Research 2020, it is biofilm mediated, diet modulated, multifactorial, non communicable dynamic disease process which resulting in the net mineral loss of the dental hard tissues. This was put forth by the Fejeskov in 1997 and Pitts et al. In 2017. And now we'll see about the theories of the dental caries. One of the earliest theories is the chemico-parasitic theory, and this theory is the most acceptable theory which was put forth by the W.D. Miller in 1890. The plaque contains the oral bacteria, so this oral bacteria will go and sit on the susceptible host, that is the tooth factor. So this susceptible host, when comes into contact with the fermentable carbohydrates, it will release some acid, and this acid production will later on lead to the demineralization of the inorganic portion of the enamel, resulting in the development of the dental caries. The another theory would be the proteolytic theory. This theory was put forth by the Bodecker in 1948. This theory states that the organic component of the enamel is first broken down by the proteolytic enzymes, which are the opening pathways for the bacteria to attack the enamel by other processes by releasing the calcium ions. Next theory would be the chelation theory. This theory states that the enamel is demineralized by the chelating agents such as the lactic acid at a neutral pH which is present in the nature, which later on leads to the demineralization of the inorganic portion of the enamel, resulting in the development of the dental caries. Next, we'll see the demineralization and remineralization cycle. This is a alternative pathway which occurs throughout the tooth. That is the demineralizing agents such as the bacteria and the sugars, whereas the remineralizing agents such as the saliva and the fluoride will act simultaneously to prevent the decay of the tooth. Now we'll see about the etiology of the dental caries. We have the primary factors such as the host or the tooth and the dental plaque, which contains the microorganisms, and the substrate and the time, which act on the host simultaneously to cause the dental caries. Now we'll see the process how it occurs. The bacteria in the plaque interacts with the sugar in the food, produces the acid, and the acid dissolves and demineralizes the tooth enamel, which results in the tooth decay. That's how the dental caries occurs. Now we'll learn about the white spot lesions and enamel hypoplasia. The white spot is an opaque structure on the tooth surface. On wetting this white spot, there would be disappearance of the white spot lesion. But in case of the enamel hypoplasia, it also represented as an opaque structure on the tooth surface. But on wetting, it doesn't disappear. That's how we can differentiate between both of them. Now we'll see about the clinical presentation of the dental caries. It is clinically presented as an smooth surface caries or the pit and fissure caries or the root surface caries. The smooth surface caries is just appears like a fans out as it penetrates into the enamel, and it is immediately seen below the developmental fault. Whereas a smooth surface caries is a caries starting on the smooth surface having the broad area of origin and has a conical extension towards the pulp. And the root surface caries is covered with the cementum and it begins directly on the dentin and it is more rapidly spreading when compared to the pit and fissure and the smooth surface caries. We can appreciate in the picture all the three cavities. Now we'll learn about the histopathology of the enamel caries. It has four zones. The first and the deepest zone would be the translucent zone, as it represents the advancing front of the enamel caries due to the demineralization, which creates a structureless appearance on the enamel. Next would be the dark zone, which lies deeper to the body of the lesion, representing some remineralization. Whereas the body of the lesion is the largest portion of the enamel, which is poorly mineralized, occurs along the trio of razzias and interprismatic lines. Whereas the surface zone is the outermost zone, which is relatively unaffected by the caries attack, and it is well mineralized by the replacement ions occurring from plaque and the saliva. We have one mnemonic for this. It is trained dentist will get the better salaries. TDBS. Now we'll see the histopathology of the dental caries. It also has the five zones. The first zone represents the zone of fatty degeneration, which is the deepest zone, which represents the degeneration of the Tome's dentinal fibers, and it is more pronounced in the acute decay. Next zone would be the zone of the dental sclerosis, and it is a transparent zone which is more harder when compared to the normal dentin. Next zone would be the zone of decalcification. In case of acute caries, it represents decreased remineralization with increased thickness, whereas in chronic caries, it is the decreased thickness with increased remineralization. Whereas the zone of bacterial invasion is the bacteria invading into the dentinal tubules, which causes the dilatation of the dentinal tubules. The uppermost zone is the zone of the decomposition, which contains the microorganisms and the plaque with the loss of collagen. And in chronic lesions, it appears darker with the black bacteria and the odor. That's how the zone of dentinal caries is represented. These are five zones, uppermost. Next, we'll see the classification of the dentinal caries. This was the most accepted classification given by the G.V. Black. The class 1 represents the caries on the lingual surface of the anterior teeth and the caries occurring on the upper surface of the posterior teeth. And the class 2 represents the caries occurring on the proximal surface of the molars and premolars. And the class 3 represents the caries occurring on the proximal surface of anterior without involving the incisal angle. If it involves the incisal angle, it represents the class 4. And the class 5 represents the caries on the gingival third of the facial and lingual surface of anterior and the posterior teeth. And the class 6 represents the incisal edge of anterior and the cusp tip of posterior teeth. Next, we'll see the based on speed of caries progression. That is the acute caries. The acute caries is also known as the rampant caries, having the rapid spread involving several teeth. Next would be the chronic caries. It is a slowly progressing, long-standing caries which is hard in consistency and it is dark colored. Sometimes the chronic caries lesions can become arrested due to the local change in the environment. Such caries is called arrested caries, which is dark brown in color and hard in consistency. Now we'll see about the pathways of caries spread, that is the extent on the caries spread. It is represented by the forward and the backward caries. Forward caries is whenever the caries cone in the enamel is larger or has the same size that of the dentin. It is referred to the forward caries. If the caries spread is along the DEJ exceeds the caries cone in the enamel, that is in a backward direction spread, is referred to as a backward caries. Now we'll see one of the most important and recent classification, that is known as the ICDAS classification, that is the International Caries Detection and Assessment System. Here the 0 represents the sound tooth surface, whereas the 1 is the visual change in the enamel. 2 is the distinct visual change in the enamel. Other would be the localized enamel breakdown due to caries. 4 represents the underlying dark shadow from the dentin. 5 is the distant cavity with the visible dentin, and 6 is the extensive distant cavity with the visible dentin. Now we'll see the diagnosis of the caries. The diagnosis is done by the visual examination or the meticulous clinical examination with a brownish discoloration of piton fissures and opacity beneath the piton fissures on the marginal ridges with a frank cavitation of the tooth surface. This can be done under the clean and dry conditions using the good illumination of the light. Now we'll see the tactile examination. The tactile examination occurs with the help of detection of dentinal caries. It usually occurs with the curved explorers and with the also examining with probe. It represents the binding or the catch of the explorer tip with the softness at the base of the pit and fissure. Now we'll see the radiographic examination. The radiographic examination is done with the help of intraoral periapical radiographs, which represents the radiolucent area in the enamel and the dentinal caries. Now we'll see the importance of the bite-wing radiographs. The early proximal caries in the bite-wing radiographs are represented as a small radiolucent notch, whereas the advanced proximal caries is seen as a dark triangular area in the proximal enamel. Now we'll see the zero radiography. The zero radiographic imaging is the image is recorded on the aluminum plate coated with a layer of selenium particles. When the X-rays are passed onto the film, it causes the selective discharge of the selenium particles which forms the latent image. Later on, this would be converted to a positive image by the process known as development in the processor unit. That is how the radiography works. Now we'll see about the fiber optic transillumination. The fiber optic transillumination in this, the caries appears like a darkened shadow. So after the tooth drying, a fiber optic probe is placed on the buccal and the lingual embrasures directly beneath the contact area. If the caries is present, it is evident as a dark shadow beneath the marginal ridge. That's how it represents the caries. Now we'll see the digital subtraction radiograph. Here we take the two standardized radiograph which are produced with an identical exposure geometry. The first one is called reference image and the subsequent image is taken for the comparison. The difference between the original and the subsequent images can be seen as the dark areas which represents a lesion in the tooth structure or in the soft tissues. Now we'll read about the radiovisiography. This is the first direct digital radiography system seen in the dentistry, and it uses the charger coupled device which works like a miniature video camera which records the images produced by the conventional X-rays and stores it in the computer memory for image processing and viewing. That's how it has an added advantage of edge enhancement. Next, we'll see about the diagnodent. The major importance of diagnodent is that it quantifies the tooth demineralization. If we observe the picture, the dental explorer is trying to detect the tooth decay, but the tooth is too small that it won't be able to detect until the cavity is made larger. And the small area being detected by the diagnodent can be seen here in the picture. The cavity may be treated while the decay is in its early stages. Now we'll see about how the functioning of the diagnodent is. The diagnodent uses the red laser light of 665 nanometer wavelength through a fiber optic probe to examine the tooth surface, passing through the acoustic signal which is represented as a digital display. Now we'll see the caries risk assessment. How it is done. It has few tools. One of the tool is the CAT, that is a caries risk assessment tool, which is based on the caries risk indicator assessed by the clinical conditions, environmental characteristics, and general tooth conditions. It is given by four categories, that is, the low, moderate, and the high risk. Now we'll see the other factor or the other tools such as the camera. The camera is the caries management by the risk assessment. It also based on the disease indicators, biological risk factors, and the protective factors, which varies according to the individual's age. And it is also represented by the four categories, such as the low, moderate, high, and extreme categories. Now we'll read about one of the important tools, such as the karyogram, which gives the chances that an individual has to avoid new carious lesions, which is represented by the dark green color, and the violet represents the diet of an individual, and the bacteria represented by the red color, whereas the light blue color is represented by the susceptibility, and the yellow represents the circumstances of an individual, how they are facing the caries. Now we'll see about the carious balance. This was given by the Featherstone in 1999. The few factors which cause the caries are the pathological factors such as the acid-producing bacteria, frequent snacking, and subnormal salivary flow. And the protective factors include the salivary flow and the fluoride antibacterial fluorexidins. This does not cause the caries. This has to go hand in hand to protect the caries. Now we'll see how the caries can be prevented. We have few agents which prevent the caries. One is the microbial shift of the caries. This can be done with a chlorhexidine dichloroconate mouthwash. Other would be the diet which we follow, which prevents the caries. Next, we'll see the application of the topical fluorides also prevent the caries. And the application of the pit and fissure sealants also will also help to prevent the caries. Others such as the remineralizing agents such as GC tooth mousse will help in preventing caries. How do we manage caries? We manage the caries using the ICCMS 4D concept. That is, we determine the caries risk of the individual, and we detect and stage according to the risk of the individual, and we plan the personalized care plan by the patient's history, and we do the appropriate and the patient preserving categories. That's how we manage the caries by the recall visits according to the risk based on the individual. That's how we do the 4D management of caries. Now we'll see what are the other caries management procedures. One would be the operative procedure, that is through the mechanical procedure, which helps in removal of the carious decay by removing the smooth surface or the deep caries lesions. That helps in removing the infected dentin and protecting the pulp, and also avoids the pain. Now we'll see the recent advance known as the smart prep burrs, which are made up of polymers, which has an innovative fluid design but works under the slow speed hand pace of 500 to 800 rpm. If you observe, the hardness of this polymer burst is greater than the carious dentin but lesser than the normal enameler dentin. So it effectively removes the infected dentin without disturbing the affected dentin. Next, we can also use the fissurotomy burrs. These are early conservative preparation burrs which helps in treatment of the hidden fissure caries without the use of the anesthesia. These are also available in various sizes. Next, we'll see the other management procedures such as the chemomechanical caries removal. Here we use the agents such as the caries sol, which is available in a gel form. It contains a sodium hypochlorite of 0.5% and the main important three amino acids such as the glutamic acid, leucine and the lysine. These three amino acids would react with the sodium hypochlorite to form these chloramines that degrades the collagen and clinically seen as softening of the caries dentin, while the healthy tissues are still unaffected. This can be stripped off using the special instruments. Next, we'll see the other agents such as the Keritex. This uses the sodium hypochloride, glycine, and aminobutyric acid. That is, the sodium hypochloride will go and react with this aminobutyric acid, will cause the release of chloramines, which causes a softening of the caries dentin, while the healthy tissue is still unaffected. The another recent advance of this is the Keri care or also called as the papain shell. It is derived from the leaves of the papaya, which contains the papain and the chloramines and the taurodin blue salts and the thickening vehicles. It works as a bactericidal, bacteriostatic, and anti-inflammatory in function. Now we'll see about the other management by the air abrasion procedure. This unit works by spraying the powerful stream of focused narrow beam of aluminum oxide particles which are of size of 20 to 50 microns with a pressure of 40 to 140 psi through a fine angled nozzle which gives a saucer-shaped cavity suited for composite restorations. Next we'll see the sonoabrasion. The sonoabrasion uses the ultrasonic instruments which have the special diamond coated tips that uses the sonic handpiece for opening the pit fissure for sealant restorations without damaging adjacent tooth. Next, one of the recent advances is the laser. It uses the erbium YAG or the erbium chromium YSGC, that is the yttrium scandium gallium garnet lasers. How it works? We'll see the laser working now. The laser is directed at the root-in area, which contains more water and molecules than the rest of the tooth. The water molecules in the decay are heated rapidly and the pressure increases and the root-in area explodes, making the popping sound. Here the laser kills the bacteria in the area and the tooth is sterilized still. That's how this recent technology of the laser beam works, by sterilizing the cavity and also by removing the bacteria.